Able to see the slide? This is the so define the breathing system is defined as an assembly of components which connect the patient to the machine. That is the basis of the breathing system. And it creates an artificial atmosphere from which the patient breathes in and breathes out. And the components of this breathing components are fresh gas flow, inspiratory and expiratory limbs. And only in coaxial circuits, both the inspiratory and expiratory will be running parallel to each other inside the tube, one single tube. Whereas all the other systems, you will have usually an inspiratory and expiratory limb. And Mapleson A has only one limb because it has a fresh gas flow coming and the expiratory valve is very close to the patient. It acts as a single corrugated tube only. And the adjustable pressure releasing valve is a very important component of any breathing system, not only to expel the excess gases but also prevent barotrauma. And at the same time, if you want to do positive pressure ventilation, this valve has to be kept closed so that you will develop enough pressure to produce an inspiratory cycle of the respiration. And the reservoir bag, what is the purpose of reservoir bag, Anish?
The purpose.
What is the volume that you use for adult? What is the volume of reservoir bag you use for pediatric cases?
Around half. There is various volume like
sizes are there, but commonly what size do you use for an adult and what size you use for a pediatric
for adults?
2
liters. 2 liters we use for adults.
2 liters average. Usually, very commonly we use 2 liters, whereas for pediatric we use only 0.5 liters, 500 ml. Okay.
Yes,
what is the purpose of this reservoir bag? What are all the functions this reservoir bag does? That may be asked in your practical exams. They may give you this bag and ask you to this question: what is the function? Why it is in this elliptical shape?
Mainly it's used for assessment of respiration.
You can monitor the breathing, okay, whether the patient is adequately inspiring and expiring. Very good. That is one function.
Then it prevents barotrauma. If there is
barotrauma, okay, it can absorb the excess volume and distant. Okay, then, but there is one important main function for that.
It's for the peak.
What is your tidal volume of an adult? It is about
500 ml.
500 ml. Then why do you require a 2 liter bag? You could have as well used the 500 ml bag for pediatric patients, which can be used for adults. So why you are using a 2 liter bag? Anybody else also can answer. Who knows the answer? Bindu or Randini? Anybody in the class can answer this question if they know the answer. Aravind. What is peak inspiratory flow rate?
4 times the unit volume.
It's the speed with which patient has to breathe in. That is called the peak inspiratory flow rate. Okay. So, in order to supply the peak inspiratory flow rate, you require a reservoir bag. If you don't have the reservoir bag, then over a period of time, patient again will become hypoxic because the gases will not reach the alveolar level. So, in order to supply or provide the peak inspiratory flow rate, you require a larger volume than the tidal volume of the patient. So, the functions of reservoir bag are mainly It acts to monitor the effectiveness of the patient's respiration. It provides the peak inspiratory flow for the patient, so inspired gases to reach up to the alveolar level. The third point is it also, as you said, prevents the barotrauma by accumulating the gases in case there is an excess gas delivered into the circuit. And why it is elliptical? It's shaped elliptical instead of being round like a football because it is easy to grip, especially when you do manual ventilation. Earlier days, nowadays you are all using ventilators in all your workstations. As soon as you
Yes, sir.
intubate and then connect the patient to the circuit, automatically your hands go to the ventilator and you switch on the ventilator, and you have very little experience of ventilating the patient with the reservoir bag. But in the olden era, the anesthetists were made to squeeze the bag all through the surgery. So instead of the ventilator being used nowadays, it was the anesthetist hands which used the squeeze the bag for ventilating the patient. So during that time, if it is an elliptical bag, it is easy to squeeze and adapt to the squeezing. Okay? If it is a round bag, it is difficult to press. That is the reason
Yes, sir.
why it was made into that elliptical shape. And sometimes you may have surface systems may have carbon dioxide absorption, and you have unidirectional valves both in the inspiratory and expiratory limbs, which make the gases flow in one particular direction. And the desirable features of breathing circuit and the essential features. So both of them are there. What are the essentials you have? You should have the system should be in such a way it is able to deliver the set concentration within the shortest possible time. The travel time of the gases should not be too long.
Yes, sir.
And it should remove CO2 from exhaled air, either by expelling the entire exhaled air into the atmosphere or absorb it from a soda line and deliver a correct FiO2. So it should not dilute the delivered oxygen and make the patient hypoxemic. And it should have
Yes, sir.
minimal dead space. Apparatus dead space should be minimal. So what is the definition of dead space?
Um, it's a space where there is no ventilation or perfusion. No perfusion is there.
It is a part of the respiratory gases which does not take place in gas exchange. It
Gas
does not
exchange.
have the oxygen going in and carbon dioxide coming out. Okay? So dead space gas may be in the anatomical tree in your respiratory tract, which is called anatomical dead space, and you have apparatus dead space. This dead space,
Yes,
what
sir.
you say in breathing circuit, is we called apparatus dead space. And this dead space gas is as good as a fresh gas. And if you see the functional analysis of the Mapleson A or McGill circuit, the fresh gas
Yes,
flow
sir.
will be coming up to the patient's end, and it patient during inspiration he takes the fresh gas flow, and then during expiration the valve is kept open, so that what happened initially part of the dead space gas and the patient's alveolar gas finally will go out. And
Yes, sir.
again the fresh gas flow will refill all these things. So that is how the patient avoids breathing carbon dioxide, because it is the dead space plus the alveolar gas which is delivered through during exhalation, which you will see shortly in another slide where the functional analysis will be shown. And it
Yes,
should
sir.
offer least resistance. Patients should not find it difficult to breathe through the systems. So that is why all
Yes,
the
sir.
tubings, everything are made quite larger diameter tubes, so that you don't get any resistance, which will again
Distance.
increase the work of breathing and make the patient suffer from muscle fatigue. And the desired features, it should be economical. It should conserve the heat so that the body does not have to heat the inspired gases. It should also provide humidification to maintain the ciliary activity in the respiratory tract. And it should be lightweight and heat resistance. and it should be usable both in adults and children and be used for spontaneous and controlled ventilation. But these are all
Yes,
desired
sir.
features. You don't have a circuit, unlike only the circuit which can be used for both spontaneous and controlled ventilation. Can you give me an example?
Spontaneous. Uh,
It's the
no, sir.
same circuit which can be used for both spontaneous or controlled ventilation. What is the example? What is the modification of Mapleson D circuit?
It's ISTPs.
No. ISTPs is Mapleson E. That is
D is a
different.
main
E and
circuit.
F are different. Mapleson D modification is
Main circuit. Main circuit.
Bain circuit. Okay, so Bain circuit
Yes,
is the
sir.
best circuit for both spontaneous and controlled ventilation.
Control ventilation.
So you remember that point also, which will be again asked in the examination. So this picture
Yes, sir.
tells you what is the circuit. This is a surface system. Okay, so there is a fresh gas flow which is coming here. It is the inspiratory limb. So the gases go to the patient, then it is expelled out, and then you have the exhalation valve or relief valve, and you have the ventilator. So if you don't have a ventilator, the reservoir bag will be coming here. So this is the basic uh, model of a circuit or a system.
Yes, sir.
The different classifications, of course, you mentioned all those things, drips and random Ekinov, they classified. And all of them, you must remember, have got these three important components. One is the reservoir, second is the fresh gas flow inlet, third is the expiratory valve, directional valves. Some of them may have carbon dioxide absorption, some of them may not have. So the three important components you should remember whenever you classify the breathing systems are the reservoir bag, the position of expiratory valve, and the entry point of fresh gas flow. These are the three things which determine how effective the breathing system will be for the patient. Okay? So these are the various examples of how these systems work. So this classification of open, semi-open, semi-closed, and closed, that is the most commonly used by most of the people who are describing that. And the each one has got its own advantage and disadvantage, which you can utilize. So the main aim is to deliver the correct concentration of the volatile anesthetic agent along with correct FiO2. Oxygen delivery and set concentration delivery is very important. The second important function of a breathing system is it should eliminate the carbon dioxide. It should not allow the patient to inhale again the exhaled carbon dioxide. If it does these two functions properly, then your breathing system will be quite safe for use. Okay, so this is how
Yes, sir.
the other systems are there, and this is the older type of the ISTPs. So you can see from what you are using in the modern day made of plastic, this is a black rubber corrugated tube, which is used as the expiratory limb. And this is the point of entry of fresh gas flow. This end is connected to the patient either through a face mask or an endotracheal tube. And this is attached to the machine. So this carries the fresh gas flow into the breathing system, and there is no reservoir bag. So this was the disadvantage, and I use this mainly for again spontaneous breathing in a very small babies with weight less than 5 kilos. We thought it should have no valves at all. So in the exam, they ask you what is the difference between the other circuits and Mapleson E or IRTPs. It is a valveless circuit, so there is no resistance at all, but it requires a very high flow because to
Yes,
avoid
sir.
rebreathing of the exhaled gases. So the fresh gas flow is delivered here. So the apparatus dead space is very small. So remember the 2 points that the apparatus dead space of a breathing circuit is determined by two things. One is it should be from the point of entry of fresh gas flow. So this portion, for example, if you put a mask or an endotracheal tube, and the volume of that plus the volume of the T-piece up to this point is the apparatus dead space. On the contrary, if you have a valve like in Mapleson A, which I will show you shortly, it is that point which determines the apparatus dead space, because the exhaled gases are going out and patient will not rebreathe that. So the apparatus dead space is determined by the point of entry of fresh gas flow in the breathing system, or the position of the adjustable or pressure relieving valve. These are the two positions by which you should determine or calculate the apparatus dead space, and you should try to reduce the apparatus dead space as much as possible. And another example you should remember and answer in the exam is, when you do a tracheostomy to a patient, which dead space you are eliminating?
The upper respiratory
Anatomical dead space. Okay, so the whatever dead space that is the gases that occupy the upper respiratory tract, right from the esophagus to the larynx and trachea up to the, because the respiratory system is divided into the dead space area, then there is a transitional zone, then there is a respiratory segment. So the last two portions of the respiratory passages are only going to take part in the gas exchange, like the alveolar airspace, ducts and alveoli. These are called the Giebel segment 21 to 23. That is the respiratory zone. There only the gas exchange will happen. All the other areas, it is only a conduit or a passage for the gases to come down to the alveoli. There is no gas exchange. So all of them act as a dead space. So if you do a tracheostomy, you are eliminating all the dead space that is above the patient's tracheostomized trachea, as well as the nasopharynx and oropharynx. So you reduce the dead space, anatomical dead space, by doing a tracheostomy in patients who require that for any purpose. So the examples of semi-closed system are Mapleson systems, circle absorber with the valve open partially, or Waters to and fro system. They are all called the semi-closed system. So this is the Waters to and fro system. This used to be the a stainless steel container which has the soda lime inside that, and it has a patient end and a reservoir bag end. So the reservoir bag is at the machine end or towards the opposite of patient end, and it has got both the fresh gas flow entry as well as the APL valve very close to the patient. Okay? So where will the apparatus dead space end in this case?
In the APL.
Near the APL, because that is located more proximal. Okay? So even though fresh gas flow is also coming here, it is up to this APL valve, this portion is the dead space. On the contrary, if the APL valve has gone behind here and the fresh gas flow is here, now in this IST field, this is the dead space. Even though there is no valve here, this is the dead space. So remember that point for remembering the apparatus dead space. And this is some history of this. Sometimes they ask selectively describe the Mapleson circuit or the breathing systems and their functional analysis. That is how the question may be worded also. So this Megill's A or Mapleson A system, Megill system, you can see the fresh gas flow is coming from the machine. The reservoir bag is close to the machine. Then there is a corrugated rubber tubing. Then there is a APL valve. Then this goes to the patient. So the apparatus dead space will end here. So this is the portion of apparatus dead space, and it requires almost a minute ventilation. How do you calculate minute ventilation?
Respiratory rate into tidal volume.
Tidal volume, fantastic. So normal adult, if you take the respiratory rate as 16 and tidal volume as 5.5 ml or 500 ml, what is the minute ventilation?
6 liter.
8
That's it.
liters, isn't it?
Yes,
16
sir.
divided by half. So 8 liters is the total minute ventilation. And you have to supply a fresh gas flow of 8 liters per minute. That is why in olden days we used to keep 3 liters of oxygen and 5 liters of nitrous oxide whenever you use this McGill circuit. Nowadays, with the modern anesthesia workstations, you have hardly any chance to use this particular circuit. So most of you are using the same double corrugated or a single unicarb coaxial circuits for anesthetic or even pre-oxygenating the patient. So this requirement for uh, the minute ventilation is a very important point in the functional analysis. So in order to avoid rebreathing, you must use a fresh gas flow of equal to patient's minute ventilation, 0.8 to 1 time the minute ventilation of the patient. These B and C are not used anymore, are not very commonly used because the positions are slightly cumbersome and they have not been, and the volume required or the minute ventilation required is almost 2 times the minute ventilation as you use in McGill circuit. So both these B and C are almost become obsolete, and the D circuit, even though for description sake you have different positions of fresh gas flow and APL valve and rebreathing valve, it is the Bain circuit which is a modification of Michelson D, which is very, very commonly used. And for spontaneous ventilation in the actual D, you have to use 2 to 3 times the minute ventilation. Whereas in
Yes, sir.
Bain circuit, when you do the control ventilation, you can use actually patients 1 time minute ventilation instead of 2 to 3. Only for spontaneous, you have to use a larger tidal
Sometimes.
volume and minute ventilation. And the ISTPs, again, the main important feature is it does not have a valve, and the fresh gas flow is very close to the patient, so reduces the apparatus space. But again, this circuit or system requires a fresh gas flow of 2 to 3 times the minute ventilation. So this is not economical, and all the gases are vented out through the expiratory limb, which will pollute the theater atmosphere. So there is a lot of global warming factor happening here. And because there is no reservoir bag in this system, you cannot monitor the patient's ventilation. But
Mm.
though it is described by IR for pediatric use, are you using it for adults in any situation?
Adults, maybe very low weight, low underweight patients.
Are you using for any adult patient ISTPs? Anybody else in the class? When you wean a patient from ventilator, what do you do? Or when you want to give supplemental oxygen to a patient who is left in the post-operative area with an endotracheal tube, patient is not fully recovered, he has some mild inefficient breathing, but not necessary to put him on ventilator. You want to do supplementation and keep the tube in situ for some time. At the time, how do you supplement the oxygen to the patient?
By
Have you not seen a T-piece being used there?
yes, sir. Yeah, weaning for I have
Not
seen
only
patient
weaning,
for
any supplemental
yes, sir.
oxygen through an endotracheal tube can be given only through a T-piece. Okay,
Yes,
so
sir.
T-piece is not only used for anesthetizing pediatric patient, but it is used also for giving supplemental
Weaning.
oxygen for any patient with a endotracheal tube in situ. Okay? So that
Yes,
is
sir.
the question they will ask you. The use of T-piece in adult is for supplemental oxygen. either to weaning or during delayed recovery cases where you keep the tube for some more time. You can use this for supplemental oxygen. So to avoid this problem of inability to monitor the patient's respiration, Jackson Bree, who was an assistant to IR, he introduced the reservoir bag. When you see this picture of the reservoir bag, can you find anything different from the reservoir bags that are there in the previous pictures here?
It's open.
It has a tail which is open. Okay? Whereas all these bags are fully closed. They are not open anywhere. Whereas this bag, which reattached to the expiratory limb of the ISTPs, there's an open tail. Okay? Why he has left it open?
To reduce the resistance, minimum resistance.
Very good. So that there is no valve here also. But the machine or the circuits that you use nowadays, they all have a valve. Okay, so that gives you the that is not the correct description what Jackson Tree made. So in the exam, if they ask you what is the modification done by Jackson Tree to IOSTPs, you should say he added a open tail half-liter reservoir bag to the expiratory limb. That is the addition that he made. Open tail half-liter reservoir bag added to the expiratory limb of the ISTPs was the modification done by Jackson Tree, so that you can assist the ventilation and also monitor the depth of ventilation, whether the breathing is adequate. That can be monitored, or you can assist by pinching this and closing this. You squeeze the bag, you produce an inspiration. You release the opening, it results in expiration. So you can do that alternatively by closing the tail and opening the tail. You can produce inspiration and expiration and do control ventilation also with this. Okay? So these are the things that happen, and this is the coaxial system where you can see the expiratory valve as well as the fresh gas flow. Now here, this is the inner tube is acting as a expiratory limb. Outer tube is acting as the inspiratory limb. So this system is called the latch system. Okay? This is a modification of the McGill or Mapleson A system. And because this has got a smaller inside tube, this will increase the resistance to breathing. That is why this is not become very popular. On the contrary, your Mapleson B and C more or less similar, and they are having the fresh gas flow and the reservoir bag position slightly changed. And so you can see this Mapleson B system, both the APL valve and fresh gas flow are very close to the patient. And in Mapleson C, the corrugated tubing is missing. That is the only difference. And this is more or less the same construction like your ambu bag. Okay? So the ambu bag, instead of the fresh gas flow being here, it will be in the back of this, but the expiratory valve will be here, and you have a mask attached to that. The only difference is this will be a self-inflating bag. So ambu bag is a modification of Mapleson C. It also asked the examination. So the fresh gas is vented through the APA valve before it can be delivered to the patient, causing you a lot of wastage is also happening. And it requires 1.5 to 2 times the minute volume of the patient's respiration, and they are not economical. So any circuit or breathing system which requires a larger minute ventilation, you have to waste a lot of money on the gases, so they will not be economical. And if they don't have a scavenging system, all the expired gases will be polluting the theater, which will cause global warming. So this is the modification of, and you can see the similarity between this Mapleson C and the self-inflating bag, and you can see the fresh gas oxygen is coming through that, and there's a reservoir bag. Some ambu bags do not have a reservoir bag also. So what is the purpose of this oxygen reservoir bag? Supposing you don't have a oxygen line or a reservoir bag, how will you be
Yes, sir.
ventilating the patient?
Mhm.
What will
Yeah.
you be delivering? Will you be giving excess oxygen or only room air?
Only room air will be.
If you don't have a oxygen line or a reservoir bag attached to your ambu bag, you will be delivering or resuscitating the patient only with room air, because this will
Yes, sir.
automatically suck the atmospheric air and refill. This is called self-re-inflating bag or self-inflating bag. So once you
Yes, sir.
squeeze the bag and you deliver a particular amount of the gas contained inside, which is will be atmospheric air if you don't have the supplementation. So you will be resuscitating the patient only with 21% oxygen present in the atmospheric air.
Atmosphere.
On the contrary, if you get a oxygen supply line alone, you will be adding a little more oxygen. But if you have this reservoir bag, which will be filled with the oxygen that is giving, you may get almost 95 to 100% oxygen supply you can deliver to the patient. So wherever you have to give the patient who is very deeply hypoxic more percentage of oxygen, you have to have a oxygen reservoir bag attached to the ambu bag. On the contrary,
Yes.
a patient who will be just resuscitated from a respiratory arrest, who has not become very badly hypoxemic, then you can resuscitate that patient with room air alone or with supplementation with a oxygen tubing just like this.
Oxygen.
So the percentage of oxygen delivered depends on the presence of oxygen reservoir bag or the tubing that is attached to the this ambu bag that is being given here. And this
Yes,
is
sir.
another circuit mainly used for both resuscitation as well as for anesthesia purpose for the patient. It can be used in OT also.
Yes, sir.
The Mapleson D system has fresh gas delivered to the patient, and it has the APL and reservoir bag towards the anesthesia machine. It is not close to the patient, and usually the tubing length is about 180 centimeters, and all the components are away from the patient, and it is the fresh gas delivered close to the patient, so the dead space is also very low. And it was previously used mainly for spontaneous breathing, but after the uh, but it causes significant rebreathing unless you use 2 to 3 times the minute ventilation. So vein circuit is a commonly kept specimen or the equipment instrument in the Viva examination. So you should know the details of that. The coaxial Mapleson D system is called the Bain system. Bain and Sporrell are the two persons who introduced this into clinical practice. And fresh gas flow here is delivered through the inner tube, unlike the lax tube, which is delivered through the outer tube. Here, the fresh gas flow is through the inner tube, and waste gases are removed via the outer tube, or the exhaled gases are removed via the outer tube, and it can be used for both spontaneous and controlled ventilation. The disadvantage of the system is the internal tube, supposing it kinks or has a break or leak, then the whole, both the tubes become the apparatus dead space. So patient will definitely uh, have a lot of mixing of the exhaled gases into the fresh gas flow, and will become hypoxic in a very short time. So this is the original Mapleson D system, where there is a fresh gas flow, corrugated tubing, the expiratory valve and reservoir bag, and the fresh gas flow has been introduced inside the tube here. So it
Yes,
becomes a
sir.
coaxial, and both the expiratory limb and sprayed with a valve as well as the bag is situated in the same position. And what is the important use of this in NORA, non-operative room anesthesia? Where do you prefer to use this particular system?
Um,
Yeah?
when when the to exhibit the
In
patient
MRI, whenever you require a
MRI.
anesthesia to be given for a child for taking an
Yes,
MRI
sir.
pictures, this is commonly used in MRI room for non-operating room anesthesia because this is lightweight, portable, and you have this is 180 centimeter normally used. You can use 3 times this length. 5.4 meters can be used for the MRI suit, where you can the machine can be far away from the inside the magnetic area. So you have a special MRI brain circuit which is 5.4 meters in length, and because the fresh gas is delivered very close to the patient, the apparatus space does not matter even if you increase the length. Okay? That is the point that you have to remember. And
Yes, sir.
E&F systems are very low resistance system because they don't have any valves, and but they also require a higher fresh gas flow. So it is not economical. It will also cause more theatre pollution. And in the E system, it is not possible to produce a positive pressure because the expiratory limb does not have a reservoir bag, and it is the control ventilation is also more difficult. It is mostly used for spontaneous ventilation, and monitoring the breathing is also quite difficult. If the drapes are there and the expiratory limb is inside the drapes, you cannot monitor the patient's breathing. And these are the olden type of the ISTPs, and this is the Jackson-Reese modification. All these things were made up of black corrugated rubber. Why they are more black like this? What makes them become blacker? Because they are incorporated with more carbon. Okay? So they can
Okay,
absorb
sir.
what is called the antistatic electricity. Okay? In the olden days, all the breathing systems were made up of black rubber, which had an excess content of carbon to remove the so-called static electricity, because all the volatile anesthetic agents used in the olden days like ether, chloroform were all very inflammable agents. So
Okay.
any fire or any spark or any electric spark can cause a fire and explosion in the OT. So they were all made up of black rubber, which had a higher content of carbon, which prevented the spread of static electricity. And this is a reservoir bag which is attached to the ISTPs. Do you know the name of this bag? Here, instead of having an open tail like this, there is a hole in the body of the bag, and the end tail is closed. Do you know the name of this bag? Okay, you try to Google and find out and tell me before the end of the class. So these are various shapes of the TPs which are used in the breathing circuits. This is the classic TPs. It's called T because it resembles the alphabet T, and this is called the modified TPs with a larger adapter for the expiratory limb. This is called the Washington T, where the inflow or the fresh gas flow inlet is slightly curved. And this is called the Norman elbow. So these are some of the modifications of the original TPs. And this you should all be very familiar with. This is a modern ISTPs modified with by masonry, where you have this tail with a white valve attached here. So original description did not have this valve. But
Yes,
to
sir.
make it convenient for us to do hand ventilation, we are using this valve, and we can adjust the opening here by threading this valve, tightening or loosening it can be done. And closed systems, there are the patient is completely isolated from the atmosphere. He breathes from the machine and breathes back into the machine. Then only it is called the closed system. And the example of that is the circle system with the APL valve completely closed. And of course, all of you should be familiar with that, having this, because these are commonly used circuit nowadays for any case. Tonsillectomies nowadays we are doing under controlled ventilation. So all of you should be familiar with that. We are showing here two pictures. Can you identify the differences between these two pictures? Both are closed circuit pictures, closed system. What is the difference you see in these two pictures?
In this, the
Any
APL
part
valve is
missing here?
yes,
In these,
that acute absorber is missing.
very good. Circle absorber is not there in this picture. Excellent. Then
Another
what is
what is
happening
the
in
name,
this
sir?
picture? It is written here also. Patient is in inspiration, that is inhaling.
Yes, sir.
Okay? So the gases are
Yes, sir.
going here. There is no leak in the expiratory valve or APL valve. On the contrary, here a patient is exhaling. He is in the expiratory phase. Gases are all
Yes, sir.
coming out, and you can see the bag is distending with the exhaled gases. Whereas here the bag is collapsed because the gases are being inhaled in there.
Inhaled.
And here you can see there is a small leak because the valve is kept partially open. Okay, so these are the,
Yes, sir.
and there is a volatile anesthetic agent being delivered to the patient through a uh, vaporizer. So the vaporizer
Yes,
is
sir.
also not here. Here only you can see
Mm.
the fresh gas flow, vaporizer absent. So in those days you get two pictures looking similar, find 6 differences are Vidyasangal. Okay? Like that you have to be observant and find out what is the difference between these two. Okay?
Yes, sir.
Right. So these are the various classifications of the Mapleson as well as the complete closed and the semi-closed circuit with their advantages and disadvantages. Okay? So Conway classification, he made a little more elaborate where it can be classified with the CO2 absorber and without CO2 absorber. And the another confusing classification is the afferent reservoir and the efferent reservoir system, where the position of reservoir bag decided the classification. So they are unidirectional and bidirectional flow. Bidirectional, of course, you saw earlier is the to and fro system, where the both the inspired and expired gases travel in the opposite direction through the same path.
Yes, sir.
Whereas all these things are classification. So if you know the basic functioning knowledge of the circuit system and the Mapleson system, and of course the ISTPs and your uh, Jackson trees, it is more than enough for you to remember. And the common examples of the Mapleson C is ambu bag and your water stone flow system. So
Yes,
these are the common things that are asked in the examination also. So this much is enough. You need not elaborate on the soda lime, the reaction and all those things. And
yes, sir.
even describing the test to find out the integrity also are not required in the answers, so that you can save time to complete the answer
Yes, sir.
in this way. So that will end the, these are the afferent and efferent reservoir system. So they belong to the afferent system. You can see the A, B, and C, where the reservoir bag is in the part of the respiratory limb, whereas in the efferent system, they are in the respiratory passage limb. And there is one more thing called the Humphrey AD system, where they had combined the two reservoirs in one afferent and one efferent limb, and system can be changed from afferent to efferent system by changing the position of the lever. Of course, this is more from theoretical aspect. This is not in common use. So this is not much of a practical exam. Sometimes they may show this picture and ask you to identify. So other than that, this is not in routine use at all. So just remember this name, what is called the Humphrey ADN system, which uses both the afferent and the efferent. Okay, that is why the name AD system is given further. So that will end the discussion on the breathing system. So